Welcome to the GSB Health Innovation Summit and the global aspect of the GSB Health Innovation Summit. My name is Michele Barry, and I'm the Dean of Global Health here, and it's my honor to actually moderate this panel. This panel is one focused on innovative healthcare services in a way to hopefully glean how our partners can sometimes offer care more affordably and create innovative partnerships in quite low resource settings. And as we move in the States into a more low resource setting, it can be quite applicable. The format and the setup that we have, the rules that I've been given, is that we've asked the panel to present 10 minutes of a case study of a global health challenge that they've had and that their organization is facing, and how they would solve it and perhaps apply it more broadly. And for the last 5 minutes, we've asked the panelists to suggest project ideas for actually Stanford business students and management students to get involved in. So those are the rules. And now I'm going to give you the bios, because we have flown in some very interesting panelists. And I'd like to introduce them. Our first speaker will be Dr. Stephen Rulisa, who is a leading OBGYN physician and head of the clinic from actually Rwanda, where he is head of the clinical research department at Kigali University Teaching Hospital. He's also the president of the Rwandan Medical Association and is involved in healthcare system strengthening in Rwanda. He's written extensively in the areas of innovation in education and training to improve maternal and neonatal outcomes in Rwanda. And he also has another interest, which is close to my heart, because I'm a tropical disease doctor, in malaria eradication. And that's something, the E word we're using, but that's something very important in a country which is endemic for malaria. Dr. Sally Stansfield, to his left, has been a leader in global health strategies for health systems for many years. She actually was at the beginning, at really the birth of the Gates Foundation's global health strategies, where she was really instrumental in starting the landmark alliances, including the Global Alliance for Vaccines, Gavi, the Global Fund for TB, HIV, and malaria, and the Global Alliance for Improved Nutrition. She's now a health systems advisor to WHO, where for the last several years, she was the founding director of the Health Metrics Initiative. Anne-Marie Moncure, sitting to the left of Dr. Stansfield, is an MBA and a fellow of the American Care of Healthcare Executives. She has managed healthcare systems on actually 3 continents in multicultural, non-traditional structures. In 2004, she left the US, where she had been the executive director of the Providence Hospital in South Carolina, to lead one of the Apollo hospitals in India, where it became the first hospital to get International First Joint Commission accreditation. It was actually the first hospital in India to do so. She then went on to China, and again worked as the president of United Family Healthcare, a US-owned hospital in Beijing, where she also achieved international accreditation from the Joint Commission. The last speaker, but not least speaker, is Dr. Frank Nyonator. Did I pronounce it right? Yeah. Good. He is a public health systems expert from Ghana, who also works with many ministers of health and many governments around Africa. Currently, he's the Director for Policy Planning, Monitoring, and Evaluation of the Ghana Health Service, including all the global health initiatives at the district, regional, and national levels. He has led the Ghana Macroeconomic Health Initiative to increase investment and reduce poverty, as well as bridge the access gap in health access delivery. For this, he's actually won a presidential award for innovative partnerships in service and delivery. So I think we have 4 very, very interesting panelists who have worked very hard in their specific areas about creating innovative leapfrog really programs to benefit health services. So I'm going to ask Stephen, Dr. Rulisa, to start. And we're going to go through all the presentations and then open it for questions and answers afterwards. Just take this.
Yeah.
Okay.
Yeah. Thank you very much for the nice introduction. I will start with Rwanda. As I told you, I come from Rwanda, and this is the map of my country. It's one of the smallest countries in Africa, if not in the world, I think. With a population of 10 million, 90% subsistence farming, and life expectancies going on now to around 56, and HIV prevalence is 3%, just to have a general overview of what is. And that is where my hospital is, right in the middle of the country and the capital, Kigali. It's one of the most beautiful countries with the rare species, mountain gorillas, so you're most welcome to walk and have a bit of tourism. Very nice lakes and 1,000 hills. So the major health priorities in Rwanda is maternal mortalities, infectious diseases, and health system strengthening. So the major causes of maternal mortality are many, but the leading cause is severe bleeding, postpartum hemorrhage in that case, which is the number one cause. And then the second is malaria, septicemia, and eclampsia, and the order continues. So there has been a lot of policy changes, and maternal and child survival are on top of the list of Rwanda's health priorities, having been identified as absolutely crucial for the long-term health of the country and its road to development. The famous slogan is that the healthier mothers mean healthier children, and healthier children mean a healthier and more productive society in the future. And so every leader in my country has to go singing that slogan. And even if you're not in the healthcare system, you have to know that. So we have several supporting documents that are cross-cutting the ministries, like EDPRS, which is we have our Vision 2020, Health System Strengthening, National Reproductive Health Policy. There are several other cross-cutting papers. And the priorities now in the maternal health are very specific that go with the Vision 2020 of the country, like to offer all the population quality, accessible, and affordable package of maternal and neonatal health systems, to improve essential obstetric and neonatal care, and to empower women and families for decision-making. We've seen this changing the society. And to ensure diagnosis and quality treatment for women with obstetric fistulas and their reinsertion into the community. So the key strategy interventions are capacity building in reproductive health, maternal death review. This includes the clinical and community level report up to the Minister of Health. An example is that now, if a woman dies or has any serious problems, it has to be reported up to the Minister of Health within 24 hours of death. So they created a system from the community health workers or from the village where the woman dies. It has to be reported up to the Minister of Health with reasons, and then it has to be audited in the view of preventing future maternal death. The family planning was made a priority and available in health posts and health centers, distribution of equipment and ambulances. We have now at least 4 ambulances in each district hospital, which can link up the whole country. That's one of the advantages that we have of being a very tiny country. So we can reach everywhere quite very fast. And then community participation, we're encouraging the community to actively participate in the health affairs. The community health workers, they have a package of incentives into the association to make them more active and involved into the healthcare systems. You may think that this is overload to the healthcare systems. Yes. So there has been also health insurance coverage. The whole country has now 97% of the whole country has community health insurance. That was reported by last year. So we think now it has gone slightly higher than 97. And the performance-based financing, this is a system that was set up to counteract the community health insurance, whereby if you have almost the whole country with health insurance, then you have overburden to the health systems. And therefore, a performance-based financing was set up to make sure that the healthcare workers are highly motivated to handle this burden of patients coming. So this means that whenever there's a case, if you manage it very well, then they get top up. It's a series of actions that are done to motivate the healthcare workers. And then motivating women to utilize health services through incentives such as free delivery if you attend 3 ANC. So if a woman attends 3 antenatal services, then there's free delivery at the healthcare systems, including if you need cesarean, including if you need ambulance to the nearest hospital or to the tertiary hospital for any complicated surgery. If you attended antenatal services, then you can have that for free. So policy changes, there has been a lot of innovative technologies. One of them is the so-called rapid SMS or phone for health. This is whereby we keep the community health workers with mobile phones with simple softwares, whereby if they see a woman, for example, attempting to deliver at home or with any complication or postpartum hemorrhage or any fever or any kind of disease, then they will send this message. It has several levels, red, green, meaning severe or moderate or something, and then it will trigger a system into the nearest ambulance systems, and they will come to pick the woman, or at least call and see what's going on and send her to the nearest hospital. So all the community health workers are now getting distributed with the mobile phones and equipped with softwares. Some districts are being experimented to use the mobile phones to report any cases and subsequently transfer the case to the nearest health facility. The internet access, the fiber optic cable is being laid all over the country, and health posts and health facilities are one of the priorities. More than 90% of the health facilities now have internet access. So we hope in the future we'll have fiber optic cable all over the country and in at least all the health systems. So what is the outcome of all these policy changes? Maternal mortality has dropped. It was one of the highest, and it was 750, then 383 in 2008. And the target for Millennium Development Goals is 2068, which we think we have maybe surpassed, or at least in this level in this year. So we think the system is working very fine, is a little bit overloading the healthcare system, but we are coming up with other packages to counteract it. And so the maternal mortality is actually going really down. We surpassed the MDG in 2015. So what are the challenges? The impact assessment. A lot of interventions are going on, a lot of activities are going on at different levels, but can we assess the impact of these challenges? That is one of the needs that we have. If you ask which one is working, it's not very easy because a lot of interventions are being launched at the same time. What we know is that they are working, but we don't exactly know which one is attributable to what extent. So if we see our neighboring countries coming to learn, I happen to be one of the team. Sometimes I don't have an answer to them to say this one is attributable to this because there are a lot of interventions in play at the same time. And so we'd be happy to have impact assessment of each. And then investment into healthcare systems, of course, in these several challenges will be great. The case of malaria. Malaria has reduced over 60% in the last 5 years. The same thing, we have been using multi-pronged approach, using the community, providing ITNs, indoor spraying, and equipping the healthcare systems, having the drugs that work better. Also, that is the same. Now we think we are in pre-elimination phase of malaria, and next step is elimination, which needs combined effort by community, scientists, leadership, and business community to work together to kick off malaria in this community. Again, we need the impact assessment. There are several interventions that are in play. It would be nice to know exactly which one is working better. But what we've come up recently is that we think we cannot achieve any of these, especially eradicating the disease, without actively involving the community. So we are shifting from the health care system where we provided all the care, all the medication, and then the community is regarded as the consumer of the product. We want now to reverse the approach and use the community be a major player in the healthcare systems. We think this can be much more effective. And we're also working into assessing which one works better. And so we came from very far, but we're still going. Thank you very much.
Yeah, indeed. Congratulations. Oof. Hello. A little bit about the global perspective. Not any one country, but we need to point out that the needs are pretty overwhelming if we look across the developing world, and if necessity is the mother, then there ought to be plenty of innovation out there. And indeed there is, because it takes a fair amount of innovativeness to live on less than $1 a day. So briefly about what's worked. I won't bother you too much, Stephen, and I know Frank will have talked about cell phones. We heard a fair amount about it this morning, but the penetration in Africa is high, varying between 30%, and Ghana's got 130%, according to their statistics. But there are 300 million cell phones in that continent, so there's plenty to be done. We've seen it used for business, we've seen it used for banking, and the potential is only beginning to be documented for responding to obstetric emergencies, as we've already heard, and there will be more. Other devices, oh no, we have a little problem with the automation here. Other devices, including PDAs, are going to be increasingly important, and I think electronic medical records, patient-held records in the developing world will be increasingly exciting. Vaccine vial monitors are something that many of you may know about, where we can tell whether vaccines, through a simple device, have been inside or outside the cold chain and are likely to be effective. Those have been very powerful in reducing mortality due to vaccine-preventable diseases. Kangaroo mother care is a social innovation that you may never have heard of, but was put together in a mission hospital in Zimbabwe originally, and is clearly documented to increase survival of very low birth weight infants by more than 5-fold. And it's very simple. You just hold the baby close to your chest. Innovative. And oral rehydration therapy is estimated to have saved 50 million lives since it was introduced in the 70s. And people have further embroidered on that innovation with cereal-based oral rehydration therapy and adding zinc to ORT, and saved all the more lives. Simple, but life-saving. Now, there's a case that requires innovation. Dr. Barry will know this is dracunculiasis, or a guinea worm. And although there are multi-dimensional interventions that have been required to prevent guinea worm, a simple filtration, this drinking straw filtration tube, has been effective in reducing transmission, as are household filtration units. These are obviously not complex technologies, but have been targeted to clearly save lives and reduce the transmission of guinea worm. There were 3.5 million cases annually in the 70s, and now it's estimated there are about 4,500 cases a year. So substantial reduction with some simple technologies. Our colleagues have already referred to the importance of doing more for malaria, and there's no question that those with that mosquito nets and artemisinin products have been instrumental in both treating and preventing malaria. This artemisinin, you may know, a Chinese herb, has been known for 1,000 years in China, but in the early 70s, the Chinese Army really kind of proved its capacity, and now artemisinin is basic therapy for the most severe form of malaria and has clearly saved lots of lives. Another social innovation is really around microfinance. This has been very powerful. You've all heard of Grameen Bank and Muhammad Yunus, but these microfinance and microenterprise interventions in developing countries can be immensely powerful in baking a revenue model, a business model into the health interventions at the most peripheral levels. And at a more macro level, you may have heard too that the French are using airline ticket taxes to help fund the provision of drugs and vaccines for the developing world, and this kind of innovative financing mechanisms are also quite powerful ways of improving access to vaccines and drugs. The advanced market commitments have also been used to encourage pharmaceutical companies to invest more in interventions that are of use for the developing world, and we think that mechanism will grow in importance in improving health for the developing world. So lots of successes, some social, some technological, and our automation is carrying on. So barriers. The developing world doesn't have its sand hill, but we need more venture capital for developing countries, there's no question. There are, however, real cultural differences. There is less, I think, encouragement of innovation in many developing countries than there is certainly in this part of the world, and more can be done to really encourage and promote innovation at the most peripheral levels and to open systems to innovative solutions. But we need to recognize resource constraints. These are not hospitals. These are not Apollo hospitals. So many of the hospitals in Africa are considerably more modest in their resources. And the people that are working on these issues work with very limited supplies, very limited technologies, and those constraints do need to be recognized. Although one of the biggest constraints is not the agricultural industry, this is to remind me about institutional barriers, the siloization of solutions across institutions, across ministries. We see this in our daily work, and there's no question that crossing interinstitutional boundaries turns out to be a very important barrier to innovation and to knowledge sharing. There is also, this is an armadillo, one of my favorite pictures, one of the things that, oh rats, don't give away your future secrets. One of the big barriers to diffusion of innovation and introduction of innovation, you may have read the work from the University of Toronto, Peter Singer and group. The scientists that came forward with their 25 innovations basically said, it's not my job to turn this into a product. So this is the it's not my job syndrome. People who have innovations, who've invented things, often do not see it as within their scope or within their capacity to commercialize, distribute, and to disseminate or introduce their innovations. So, and there's another problem. Sometimes innovations don't really solve the problems we think they do. Particularly for the developing world, one finds that folks who don't understand the context very well will sometimes develop solutions that cause more problem than they solve. So we end up with technologies in rubbish heaps. So there is a sort of vicious cycle that could be turned more virtuous by investing in each of these spaces. There is weak demand for innovation. There's often very little support for translational research. And the institutional frameworks within developing countries don't have mechanisms to approve products or support manufacturing or distribution of these things. So although there are many barriers, we think that there are solutions. So what can we do? First of all, one of the big solutions, I think, is to shine light on successes. That means documenting the cost reductions, the improved health outcomes that technologies can deliver, and also basically to show that it's the winners who innovate. It's the winners who promote innovation. It's the winning institutions, it's the winning individuals, and the winning businesses that are open to innovation. We need, however, to make sure that those who innovate understand fully what the context is, what the limitations are within the context in which they're operating, and what the real health problems are that need to be solved, so that the power of innovation can really be directed at the most important barriers to improving health. So we need to listen to the users and make sure that that there are more resources available to really unlock the power of innovation, to really improve venture capital, improve the funding available for translational research, and to make it clear to countries what proportion of their budgets should be reserved for R&D. There needs to be, in order to bake it into cultures, in order to bake it into societies, we need to make sure that we institutionalize the power of innovation and make sure that there are mechanisms to really share information. I think people in this room could be very instrumental in helping just to develop a business plan. Often the inability to move an innovation from an idea or an invention into a commercial product is related to the inability to truly articulate a business plan. That can be also instrumental in making sure that we mobilize the capital and figure out who else needs to be in the room. Brokering alliances is another thing that this group could help with. And I think increasingly we will see that those alliances are not just within nations, but really are across national boundaries. I think the climate is better now than ever before for collaboration across countries. And while Rwanda or Burkina Faso don't need a Food and Drug Administration, they do need institutions that help to enable the licensing, regulation of products and devices and drugs and vaccines. These institutions need to be held accountable for delivering solutions instead of barriers. Ours is often rewarded for its barriers, but I think we need to make sure that there are institutions, and they may not be national institutions, they may be regional institutions, that really are rewarded and structured to deliver better health. The policymakers need to get engaged. There should be tax incentives for the venture capitalists. There should be rewards of other kinds for the innovators, and there needs to be budgets set aside to take care of all of that and to fund the translational research. And then, perhaps most importantly, we need to make sure we take care of the next generation of innovators, involve them early, and make sure that they see innovation as something within their power and their responsibility to their society. So plenty of actions to be had. They need to be push as well as pull. I heard someone mention earlier today. We should make sure that we not only build institutions, but that we reward those that innovate. Another thing that this group could do is help map innovation systems and really document for countries what works. in terms of institutional structures, in terms of funding structures, and really help make sure that we provide models so that nations can get their policies in order in a way that will really promote and foster innovation. So we look to this group in this room to make sure that we are able to harness innovation to really improve health outcomes. The potential is immense, and the only thing larger, I think, than the need is the capacity in a place like this to really deliver innovation for those who need it most. Thanks.
Gives me a moment to just discuss the fact that we were at Stanford very lucky a couple months ago to get an $8 million NIH grant to try called CID, the Consortium of Innovation Design and Evaluation, to train innovators in countries like Rwanda and Ghana. So I open our hearts that we have this opportunity now, and maybe we can offline later have some discussion, Q&A. We're working on some of those solutions stuff.
Good afternoon. Just so you know, I don't have a cold. I've sounded like this since I was 6 years old. This afternoon, I'm going to speak to you about the challenges and opportunities that drive innovation in building the capacity and capabilities necessary for a healthcare delivery system. You know, this has now become, it's really a global topic. We're hearing global innovation this afternoon, but even in the earlier sessions today, we were hearing about the need for healthcare innovation in the U.S. And we're 235 years away from our founding independence and 43 years away from the formation of one of the largest not-for-profit investor-owned companies. So how does a company like Fortis Healthcare create a pan-Indian and global presence that provides value medicine and is medically inclusive? Let me define value medicine. Value medicine is going from chasing quality or looking for quality to gaining quality improvements and being able to improve it without moving up the cost curve. And medically inclusive is exactly what it means. Be open for everyone, be affordable for everyone, be a safety net for the entire country. India has 1.2 billion people, and during the last decade, its rate of growth was 17.6%. There were 28 states and 7 unions, and it became a democracy in 1950. And to most of you, that seems like a very long time ago, but it was only 6 years before I was born. Indian healthcare has 70% government hospitals, 30% private hospitals. Those private hospitals are all sorts of different mixes. You have small individual-owned nursing homes, which is what they call anything smaller than 10 beds. And then you have large tertiary care facilities that have 1,000 beds or more. And 30%, so that 30% provides care for 80% of the population, which is pretty impressive. The healthcare spend in India is 4.1% of its GDP, and 70% of the healthcare expenditure is out of pocket. 22% is paid for by the government from government insurance. 1% is regular insurance or personal-owned insurance, and 7% is that infamous other. Fortis, the health insurance market size, so I can put that in context for you, in 2006 was equal to 494 million USD. In 2009, it was 1.4 million USD, and the estimate for 2015 is 6.2 million USD. Which gives you an idea that now is the time for private healthcare development. Fortis's vision reads, to create a world-class integrated healthcare delivery system entailing the finest medical skills combined with compassionate care and medically inclusive. Simply put, they want to be globally respected, known for clinical excellence, and have distinctive patient care. You know, the high-touch pieces. The company profile. Fortis was founded in 1996, 46 years after independence. They opened their first hospital in 2001 in Mohali. The second hospital was opened in 2003 in Noida, and the third hospital was acquired in 2005. Today, they have 56 facilities that span 15 states and 30 cities. If the growth were linear, it would be 9.3 facilities a year, but it's really been more exponential. I'm going to break the challenges that they faced into two dimensions. I'm going to do physical dimensions and non-physical dimensions. Under physical, you have organizational structure. What should this look like? What should this delivery system look like? How can it best reach across the entire country down into rural locations? And then you have plant property and equipment. How do you create a system that has tertiary care but doesn't duplicate or raise cost by duplication of efforts? On the non-physical side, you have things like brand identity, because if it's an investor-owned company, you've got to build a brand. You've got the values, you've got talent, and you've got operating systems. They had plenty of research to reference. Back in the US in 1961, there was an article published in the New England Journal of Medicine by White, Williams, and Greenberg called The Ecology of Primary Care. They've had plenty of models to emulate. Back in 1968, HCA formed 192 years after our independence, and now has 273 facilities, and their evolution was to hub and spoke. The model, or the principle, was deliver care closer to home. At the time that HCA was formed, you had the academic teaching hospitals looked very much like government hospitals in India. They were overcrowded, understaffed, lack of resources, and it was just the safety net for those that couldn't afford anything better. They began with community hospitals of varying sizes, and then began placing medical office buildings next to them to be feeder systems. They then took that and extended their network through satellites, and then home health. And when it became required to own physicians, they began acquiring practices. Then large academic medical centers truly could do what they needed to do: complicated cases, trauma care, the training of our medical community, and uncompensated care when required. Now, too, the academic medical centers have migrated, and they're now building their own small satellites and hub and spoke systems because they, too, need to offload some of the care that is being delivered. Fortis chose the hub and spoke model. 6 years after acquiring their third hospital, they've now been able to enter into Tier 2 cities. Tier 2 cities then being able to reach out to the more rural markets through technology. Telemedicine has developed very, very rapidly and is used widely, partially because the discussion isn't who's going to get paid for this, it's what do we need to do to make sure that we have a safety net for all. The local model was the Apollo model, and Fortis looked at some of the challenges that Apollo had faced and decided that they needed to do things a little differently. Instead of having physicians that were private practitioners that could come and practice in the facility, they decided to have owned physicians so that they could control quality and control behaviors. They deployed a very, very strong IT platform, which was necessary in order to get continuity. The extensive use of technology and putting the right technology in the right place. 3 Tesla MRIs and CT 64-slice CT scans are in only the major cities. There's a system-wide talk. Being able to communicate across a network is really important. As you're acquiring facilities that quickly, when you take a hospital that had been owned by someone else and really need to move it into the Fortis system or into any healthcare system, they need to understand what the expectations are. There are only 3 reasons people don't do what you want them to do. They don't understand, they don't know how, or they're just not going to do it. Fortis engaged McKinsey to create operating platforms that were non-medical. The Fortis Financial Operating System, the True Revenue Management System, and the Purchasing and Supply Management System. Fortis organization has now moved further on the value curve. They've just agreed, just in the last 2 weeks, to, as a company, as a system, to take on their first medical protocol, which will then begin to be able to give consistent outcomes and measurable outcomes, because the same things are happening across the system, and they're going to use it in the use of antibiotics. Some of the additional factors that have helped make them successful is their ability to execute mergers and acquisitions, the ability to integrate a new organization into the Fortis network, and also then the ability to turn around a failing entity. The foundation of all of this has got to be trust, especially when you're talking about employees that make, that this is their livelihood, that this is what feeds their families, that if their job went away tomorrow, they would not have any opportunities. Fortis, by 2012, will employ 9 million people. What's made India be able to do what they've done with the infrastructure challenges that they face compared to China, which is 20 to 30 years behind India in healthcare? Part of it's been government interaction and government support. The government's done innovative programs to help serve the underserved or the underserved population and uncompensated care model. They've given land in exchange for free care by setting up boards. So most of these hospitals have obligations to set up 150 of their beds in a certain geographic region to take care of patients that cannot afford their care. But once you move into the Joint Commission arena, you have other considerations. You have to have the same standard of care. So in years past, the model was one large room like this with 150 beds with no separation of patients through curtains or bed rails or side rails, or medications weren't controlled by the hospital but brought in by the family. But Fortis and the for-profit players in India are now following the same guidelines we do here. It may be 150 people in a room, but there's patient confidentiality, there's privacy, there's respect, and the standard of care, the medical treatment is the same as what you'd get if you were a paying patient. So what's Fortis's challenge going forward? They need to continue expansion into more states and into more rural locations. And technically, that's an India challenge. They need to be able to deliver care at the lowest common denominator, to be able to make sure that primary care is affordable to all, that the cycle of poverty isn't increased when a farmer suffers a heart attack and can't afford care. So they've introduced important insurance schemes like ₹1 a day for catastrophic care. So that farmer only needs to set aside ₹1 a day and has care for a catastrophic illness. They've done some episodic care insurance programs. So a woman that finds out that she's pregnant can purchase an insurance policy just for that term that will take care of all of her prenatal care, as well as the delivery, as well as anything that might happen to that baby during the delivery process. But getting even closer to home is going to be more and more important as they move into rural areas. But the infrastructure challenges are great. Greater integration. Next month, Fortis will open its first freestanding dialysis center, and they've got specialty clinics for metabolic diseases, endocrine diseases, and diabetes. But what about home health? What about rehab? What about all the things that we've seen cycle through the U.S. and through more developed countries? They have to be able to deliver that facing the infrastructure challenges. But the greatest challenge for them is going to be finding the talent to sustain the growth that they've achieved. The challenge I raise to all of you all is the opportunities are limitless, but you need to find cost structures that will work in less developed countries. I can't tell you how many times when sitting in Beijing or in India that I had people come and bring the greatest of ideas, but that had been used here for quite a while, but they wanted outrageous sums or sums that we would pay here. It's just not going to fly. The country can't support that. The economics of it just won't work. To all of the students that are looking at their healthcare careers, do something you love. If you do what you love, the money will follow. Take risks. Find a mentor, be a mentor. Remember, the culture counts. If you join an organization and you just don't find that you fit or they don't fit your values, go somewhere else, because in the end, being true to yourself and true to your ideals count. Give back, and most importantly, do better than the last generation did with being the healthcare stewards. Thank you very much. There is one correction to my bio. When I was in Beijing, we raised $100 million, not $1 million. There's a big difference.
Thank you very much. I realize that it's 10 o'clock in Accra, so I'll be a bit groggy, but I hope I can get my message across. Since morning, I've been listening to all the presentations, and I realize that we are 2 worlds apart. Basically, what for us is the innovation for the basic need for health care delivery, just the basic one, on the rocket science ones that were presented. But let me just maybe by way of introduction show you where Ghana is within the context of the world and where Ghana is in the context of Africa. I will start from the African level, where most countries in Africa, just like my brother Steve said, we are gradually moving into a demographic transition. And in so doing, we are facing a triple burden in the healthcare delivery. Existing communicable disease that is there, the emerging burden of the non-communicable diseases within the context of a dysfunctional health system. So you can imagine what the situation is there that we face. And I must say that all is not that gloomy. There have been some progress in Africa. For the past 10 years, we have had under 5 mortality rate drop from 179 to about 127 per 1,000 live births. And as Steve said, estimated average maternal mortality fell from the 850 per 100,000 live births to some areas 300, 400, and averagely 620. But a lot more need to be done to achieve the MDGs in their region. This is within the context of the weak health systems, inadequate service delivery, inadequate resources to fund the service, weak health information system and technology, poor leadership and governance, weak multi-sectoral response, and also low priority accorded in the health within the context of national economic and development policies. But for Ghana, we've made some good progress in reducing certain disparities over the last years, but substantial disparities still remain, impeding our overall progress towards the MDGs. We also have the fact that health equity is a critical issue for Ghana's development, and for practical reasons, not just for moral ones. And the fact that We have, within our current plan, proposed a number of viable strategies and innovations to reduce these huge disparities. And we recognize that if we do not implement these strategies, we will not make an impact on the life of our women and children. So I will talk about only two of these initiatives and innovations. And as I said, basically for us, innovations and initiatives are more towards the basic, how to improve the basic service provision, how to improve equities, how to send services down to the communities. So I'll talk about, and it's similar to what Steve said in Rwanda. I'll talk about the National Health Insurance Scheme, which basically we are wondering whether it is a hazardous experiment that we are conducting or it's the way forward for the sub-Saharan African countries. And I'll come back to that one. And I'll also talk about the mobile technology using mobile phones. As Sally said, mobile penetration in Ghana ranges between 60 to over 100 and thereabout. So that is something that we needed to tap on. But let me start with the National Health Insurance and give you a brief pick about what we have as a social health insurance scheme in Ghana. That we have a national health authority at the national level that regulates and provides, supervises and provides resources to the National Health Insurance Fund, which takes premium from subscribers and so take insurance, 2% of the national health insurance on services and goods, and also takes from the social security contribution of all workers. And again, government then provide additional support, and other donors also provide support to it. The insurance scheme in Ghana is typically what we call it grassroots insurance scheme. Every district has a scheme. And you can imagine 170 schemes that are which are autonomous, independent of each other, which are being coordinated at the national level. And that requires a certain level of innovative thinking. Currently, we have 145 of those schemes that are being managed by the authority at the national level. And we have 4 private schemes, and there are mutual insurance schemes that are also coming up. The membership structure is such that, as I said, approximately the premium is, for the informal sector is that they pay $3.5 to about $30 range of activities that determine what premium you pay. And this is yearly premium payments. And as I said, we have formal sector contributors and also a huge exemption group that is for the indigents, children under 18, elderly, and the pregnant women. And the benefit package are quite a huge kind of array of packages that covered over 95% of all the conditions that afflict people in Ghana, including outpatient care as well as inpatient care deliveries, diagnosis, drugs, and all emergencies. I must say that since 2003, at least registration has gone up, and currently we are about 62% of the total population. Remember we said at the start of this insurance scheme, we said we'll get about 100% of the Ghanaian population enrolled in within the next 5 years. And clearly this seems to be on target. But active membership or accessing services are lower than the total number that is on the register. And currently it's about 48% of that. And we have realized that since inception, at least there have been a gradual rise in the assessing service delivery at the outpatient level, which is increasing. And we also realize that gradually out-of-pocket expenditure for most households are reducing, basically due to the introduction of this insurance scheme. There are implementation difficulties. We recognize now that the fact that those of the high quintiles are getting more benefit from the insurance as opposed to the lower quintiles. Meanwhile, the strategy was to make sure that the lower quintiles in the population are the ones that assess it. And these are challenges that need to be done. There are problems with the cost escalation issues that comes in there, which we are also having plans to change. And these include really reorganizing the scheme to so that there will be a mixture of provider payment mechanism. We are leaning towards capitation for primary care services, and then the DRGs within the context of hospital services. I must say that this innovation is driven by a strong political leadership and drive, and learning from previous experiences that we have, and also willingness as a country to be bold and innovative. Clearly, ILO has told us right from the beginning that the way we are progressing, if you don't take time, the insurance will go bust in the next 5 years. We are at the end of the 5 years. It hasn't gone bust yet. We know that, yes, we will really prevail. But again, we need to be realistic and address the issues that this throws up. And this is at the government level, and clearly it is something that for a typical African country, we need to really take on board. The second innovation that I want to talk about is the mobile technology for midwives, which Sally made reference to. And this actually is addressing services for pregnant mothers that send information to, they are registered, and then the mobile phone that is within the household, the one that is registered, and information is sent on regular basis to the pregnant mothers as to what to do at any point in the pregnancy. And clearly, voice messages are also sent in the local languages so that at least people do understand and it's tailored to specific challenges and beliefs in the locality. It also has nurses application that make sure that information from the pregnant woman are captured, and it also reduces data capture problems that we have in the manual transmission, and make sure that data, submitted data is automated in many of the monthly returns from the nurses, saving time and accuracy. And for the feedback we got from the clients that for the midwives, for the pregnant women, they are quite happy about it. They said that this is fantastic. This is what they've been expecting for a long time. One said, I like the messages, especially on the nutrition, and I was able to share this with my husband so that he could hear it, and now I'm allowed to get many things such as beans, vegetables, and ground fish for my soup, and sometimes to eat, because the local tradition is that when you are pregnant, you don't take most of these things. But once the information is coming, and both the husband and everybody in the household is hearing it, at least it provides them with information that it is not them that wants the food, but then this food is for the good of the pregnancy. And various interesting issues coming up from, as feedback from the pregnant women using this technology. But it's not only the pregnant women, but also the nurses that are looking at. We have the nurses in the community also giving us positive indication, feedback as to what they have been experiencing and how it helps them to get proper documentation going on. And for us, this is something that is improving our service delivery. But we, as an African country, we are faced with and inundated always with people with these solutions coming Most of these solutions, 3/4 of them do not work, but then you get them being pushed on the throat of service providers. And apart from the fact that we are not too sure about the solutions, we are also not too sure about the intent of the peddlers of the solutions. And so we have a variety of solutions out there, and you have contractors that are coming, descending on the ministry for a lot of this. And we have to be very careful and trying to think through whether these are genuine or not. Working with Stanford Graduate School of Business, I think we believe seriously that we see areas of collaboration. As my colleague said, policy analysis, policy implementation reviews, current health sector policies have been effective in addressing the challenges. But yeah, we can work together with the school to do some analysis in these areas. Impact evaluation, as Steve also said, impact evaluation of our policies and strategies, huge areas that are available for us to work together as a ministry and as a school to see whether these interventions are working. Capacity building. For the students, we have been doing attachments with students from other universities, including Columbia universities, and so I don't see the reason why we cannot do that one with the Stanford University. So clearly there's huge opportunities that we have out there. Last but not least, operational research that is clearly out there and is just unlimited for us to have that kind of collaboration between the school and the Ministry of Health. So clearly a lot of opportunities exist. We are innovating, we are at the forefront of innovation, and we need to see whether these innovations are working, and we need to work closely with you so that this can be fruitful for both parties. Thank you very much.
This is addressed partly inspired by one of your slides on the hockey stick, or the growth, the sudden growth in
Could you
visits.
introduce yourself first?
I'm sorry, I'm Bill Evans. I work in the device industry. But I noticed that you had this incredible uptick of demand, and I was just wondering, this must be an issue as your health systems grow. Obviously, that was impressive if you achieved those visits. But I wondered, do you have any particular lessons? I mean, how did you deal with that, what must have been a substantial strain on the system?
Yeah. Well, shall I answer?
Yes, of course, yes.
Oh, okay. I thought we would take a couple before.
No.
No, you are very, very right. And clearly, with the increase in numbers in OPD attendance and actual hospital attendance, the health workers, the numbers of the health workers are not increased. So you could see that it becomes an increased burden for the existing health workers. And the complaint have been that they are being overwhelmed by these numbers of attendance, which are coming and making, and so it's created a bit of conflict and tension between the patients and the service providers. And the patients are feeling that they are not getting the quality of care that they need. They are being treated, and most of them say that even the nurse doesn't touch them. He sees them and then just writes a prescription because there's a whole load of patients sitting out there. And so there are, at least on the part of the patients, a lot of delays. On the part of the service providers, a lot of workload on them. So the challenge for us is to, first of all, expand the services, the service provision areas, also get a lot more service providers into the system. And so that has been a critical challenge that we are trying to balance out.
Your numbers improved as well, didn't they? Your statistics, your data. So did you have to innovate? Was it just more resources? Or?
No, as I said, the numbers of the service providers hadn't increased, but the numbers of the patients had increased. So that's the workload. The workload had increased. And so there's a lot more sacrifice on the service providers to do a lot more work. And then they are not even provided with any more additional incentive. And so there's a lot of cry for additional incentive. And the labor front is also, within the health workers union, is also up in turmoil. And what we are trying to do is to contain all the situation whilst addressing them as we move along.
I'd like to take this next question, but I just want to follow up on that. With such a huge manpower issue in African countries, maybe I'm sure this audience recognizes that Africa has only 4% of the healthcare workforce, and many of us are working on that. How do you roll out this national health insurance in both Rwanda and in Ghana? And I do want to take your question. Do you want to just comment on that just briefly? Stephen or? Health workforce, when you have such a lack of health workforce, how do you upscale that kind of national health coverage?
Yeah, so what happened is that we first focused on the patient side and put all our energy on increasing coverage on health insurance. So in the last few years, we managed to find that over 70 or 80% of the whole population had health insurance. And so the health systems were overloaded. So we now refocus on the health systems again because the healthcare workers were overloaded. I was overloaded. And so we had to set up a system of performance-based financing, which was actually meant to motivate the healthcare workers to bear the burden of the patient load that is coming, that is big, and the infrastructure was not actually upgraded to the same level. So the performance-based financing was actually meant to keep the healthcare workers going, like motivating, topping up on their salaries, on their time spent walking the extra mile to cover the patient load that is coming up. So both of them are now going up at the same time, polishing on the performance-based financing part, and also on increasing health insurance on the patient side. So it's a balance. Sometimes the other side is heavier than the other. Sometimes you put more energy on lifting the other one. So it keeps going that way. Yeah.
Hi, my name is Kit. I'm from the medical device industry as well. This question is for the whole panel. Could you recommend some funding opportunities or strategic partnership that innovators should consider to secure funding for early development or even deploying some pilot study globally?
Yeah, let's take the issue of the Global Challenge Fund that is out there currently. And what we're saying is that the smallest funding to test out innovations, how can we even deliver, let's say, look at our commodity stock, anti-malarials. There's always stockouts. How can we use mobile technology to resolve those problems? And so this funding from the Gates Foundation being available that 100,000 innovators can try and see and provide solutions to things like this are areas that are open for innovators like you to take up. But our countries, I must say, do not have that kind of resources to be providing for innovators. And so external innovators like the Gates Foundation, and I know other global organizations are also moving into that. We currently have the Doris Duke Foundation, which is also providing some huge resources for innovation as well, how to deliver services in countries like Ghana, where the resources, the services are not there and the systems are in shambles.
Just And if I can just add to that, in addition to Frank's point about the Gates Foundation's Grand Challenges in Global Health program, I think is a good one, and the Doris Duke. And then there's There is now one U.S. Agency for International Development funded program, and there'll be 2 more within the next few months that are specifically focused on health technologies and helping to take ideas, innovations, and accelerate their development into products. And there should be not only support in terms of the financial support, which unfortunately is often very modest, but a fair amount of investment in making sure that the appropriate partnerships are there for field testing and to accelerate licensing.
Depending on the country, and there are opportunities that are government-sponsored. For instance, China is very, very interested in innovation right now and reforming their healthcare system. So there is funding available through the Chinese government. And in other countries where you have investor-owned companies, sometimes they'll sponsor some innovation, some projects. So those would be good sources.
Hi, first, Amy Lockwood from the Center of Global Health here at Stanford. And I just want to thank you all for your really amazing presentations. It's so great to hear so many voices from around the globe. And one of the things we've heard today are all of the ways that the U.S. system can be helpful. We've heard lots of presentations about good things that we get to bring other places. But I know from some conversations I've had today with you and other conversations from earlier that there are things that we can learn from you. And I'd love just each member of the panel to identify 1 or 2 things that you think, given what's happening in the U.S. healthcare system, that we should be looking towards our neighbors in other parts of the world to learn from.
I'm willing to start. I think, one thing, Rwanda, and this builds upon our conversation over lunch, which was quite impassioned about where U.S. health reforms are going, and particularly the investment in information systems. It's very interesting to listen to Todd Park before lunch talking about information liberation, and I learned a lot from that. But I think we can learn even more from looking at what a country like Rwanda is doing. They have really created a overall information systems architecture that is specifically designed to serve the functions of the health system, whether it's financing and health insurance, or commodities management, or human resource management, or service tracking, and public health. But they've really taken great care to unpack all those functions, make sure that the information system is designed not only to serve each of those functions, but to integrate. And it's extremely powerful. It's one of the places where one of the domains in which I think developing countries have a huge advantage relative to the overdeveloped world, where I think often our institutional barriers and proprietary barriers are much higher to trying to create an integrated system. So I hope that the U.S. will watch carefully the kinds of health benefits that can be delivered by having a really integrated information system. And I think Rwanda is well in the lead on that.
From an operational standpoint, we've made things very complicated in the U.S. Instead of finding simple solutions, we seem to find this most complicated solution to protect ourselves against malpractice liability. And what I've seen in traveling around the world is that sometimes the simplest solutions are the best. We don't need expensive pharmacy systems. There are ways to provide safe, effective, and secure medications without having a Pyxis on the floor. Where Pyxis is a pharmacy distribution system that no hospital in Asia really can afford at this time. Infection control, in sterilization, there were things that we did in the 80s and the 70s that worked really just as well, but we moved it up the scale and have made it more complicated for ourselves, making sure that everything is single-use devices And there are things that can be sterilized and reused. And so I think we need to kind of sit back and look at what's essential to providing care, good quality, safe care, and what's just fluff. And what are we doing just to protect ourselves?
I started my presentation by saying that even attaining the MDGs is not a rocket science kind of issue. So the interventions are out there already. What we need to do is to just get the interventions to those who need it most. And that's what the U.S. need to start understanding, that you don't need to start inventing the interventions. The interventions are there. Send it to the people who need it. And strategies to send these interventions to homes, communities exist. And there's a lot of countries that are really perfecting in the community-based service delivery, using cadres like community health nurses, not public health physicians, whose production is at a high cost, but task shifting to cadres that are able to send these interventions to the homes. It's been done in Ethiopia, India, Bangladesh. That kind of service delivery does not take you huge capital entries. But again, since you are in the futuristic world, you want doctors to be the ones that are providing immunization. Do we need doctors to provide immunization? So those are things that you can learn from other countries.
Thank you very much. What I can say on this question is that what can U.S. do is very interesting. We would like you to be on board, of course. So as we run very fast to our target, I consider this as a game. So if you're in the game, you need someone to be on the side and blow the whistle and say, hey, you're off track, for example. I am one of the few people who have kept both legs into research and clinical medicine, but the balance is not very easy. So sometimes you're overtaken by the health systems and you need someone on research to say, hey, this one does not work. This one works better than that one. So if you're on board, that's where we need someone from outside to keep checks and balance into the systems that are running. And the other thing is research. Of course, we need to generate enormous amount of data, especially in our countries where we're running very fast. We need research to be ahead of policy making, of policy formulations. If we don't, then policies will be ahead of research, which means that they are not using correct data that are generated locally. So we need science to be on board. We need scientists to be on our side and generate enormous data so that any policy change can have a backup of research data on ground. So that's why we need more scientists, more clinical-oriented people, more system strengthening on board to help us checks and balances. Sometimes I find I have a lot of research questions to be implemented or to do research, but I also have this burden of clinical medicine, and the balance is not easy. Sometimes you're taken up by patient care, and all the research questions that are not answered, you meet them in front anyway, and they are still not answered. So if you have someone on board to help answer these research questions, it will be very interesting. And I think strengthening the healthcare system would be much easier in that way. Yeah.
Hi, I'm Kevin Braithwaite from Root Space. The question I have relates to the private sector, particularly entrepreneurs. What is the role for entrepreneurs both here but also in India and Africa in delivering some of the services and products and technologies that are the greatest challenges that you face? I'm saying this because I'm particularly impressed with some of the things from Stanford, such as Embrace, Frontline SMS Medic, and I'm very interested in your views on partnerships between countries. Thank you.
I can start the role of entrepreneurs. I think that is all that we need. So we need entrepreneurs to partner with government, with institutions, with the health institutions. We talked about the mobile systems that are working, that are being tried anyway. So if we have entrepreneurs to partner with institutions, that is what is lacking so far. you have entrepreneurs who can be into the business of innovation, for example, in mobile systems, and how, for example, how can the community be part of the systems and continue in their business. That's where we want entrepreneurs to partner with the local systems in improving the healthcare systems in general.
Yeah. Just to add to that, I think one thing that I certainly see working at the World Health Organization is, there's a sort of European view of healthcare systems, and which I think is largely prevalent in Africa and Asia as well, really puts government so much in the driver's seat for not only creating an enabling environment for services, but also often just delivering services. And it's a problem because as we know, not only here but elsewhere, healthcare systems are often kind of on the brink of bankruptcy, or at least in a state of chronic insolvency. And so what's been missing, I think, is the revenue model. So, as you point out, I think if there's not a business model, if there's not a revenue model to keep a healthcare system running, we're always going to be behind. It's never going to work. It's never going to be sustainable. So I think we need those entrepreneurs. We don't just need those entrepreneurs. They have to be. If there's not, the business model has to be revisited and baked in and made central to the way in which health systems function.
I think there's a long list of goods and services that the healthcare systems in India specifically need. For instance, employee education, some of the basic educations we have here to be delivered in local language and online that are low cost and can be trackable so that you get your mandatory trainings in every year. I think there need to be water purification systems so dialysis can be delivered at home, methods for not just providing home health, but creating the structure, the safety of home health and the infrastructure of the goods and services. So the list is very, very long. Where I've seen it fall short is that when you have someone that's interested, they want to sell you a U.S. product at a U.S. price with no modifications.
Yeah. And I guess that is the caution that I wanted thrown out earlier on, that from where I sit at the government level, every day you get over 10 entrepreneurs coming to sell to you the same solution. And the price range from the cheapest that you can get to the US price or whatever, from the Indian price to the US price. And the dilemma that we face at that level is, so which one is the best one? And then most entrepreneurs will not come with proposals also for the capital layout, knowing very well that the countries do not have those capital layouts. So the partnership depends on the integrity of the entrepreneurs, and we also need genuine entrepreneurs to work with. Not everybody selling anything for us to take up.
I'll give you a solid example. Are any of you know the Healthcare Advisory Board out of Washington, D.C.? Okay. It's a think tank that has been in the U.S. and functioning for many years, and they have developed all they're the bellwether. And all the research is things like how to create a service line when we were looking at service line leadership. And so when you sit down in Asia, and I'm sure in any of the countries, and you say, well, it tastes like vanilla, or it looks like this, and they've never tasted vanilla, or they've never seen it, it's very hard to explain a concept. So Healthcare Advisory Board, shortly after my facility attained Joint Commission accreditation, came to make a sales call. And I was very excited to see that they were interested in India. And when they laid out what the costing structure would be to buy information, not new information, not country-specific information, just information that had been developed and was old information in the U.S., they wanted to sell it at the same full price that they had charged U.S. facilities 5 years earlier. It took quite a bit to convince them that that it was just not going to work, and they did eventually come around and work with us. But for most hospitals in Asia, it's still much too expensive. And so that's not something that even needed to be reinvented. They just needed to be willing to sell it at a different price.
I'd like to share anything from Indian biodesign. Would you like to explain the Indian biodesign program? Come up and talk about our program here where we're trying to partner in India and work with innovators on both sides to come up with a business plan. So why don't you explain Indian biodesign?
Yes.
Okay, I relate to that side.
The India Biodesign Program is in collaboration with the Indian government, Stanford University, and the Indo-US Technology Forum. I'm a current fellow. My name is Mridu, I'm sorry, Mridu Smita Chaudhary, and I go with Mridu. And the whole program's focused on developing low-cost and possibly low-tech medical devices for India and possibly most of the developing world. So I'm currently in the 4th batch. This program's been running for 3 batches previous to mine. And we have come up with some products, like there are 2 interns who came up with this cost-effective way of transferring patients with a bed sheet, which is very, very, it's durable and it's easy to transfer patients. And there are other projects which are currently undergoing R&D and trials, like and there are trauma pads. We call them trauma pads. That's for patients who need limb immobilization. So it's basically like a program that's focused on developing products for India and not the US, but may be translated back here.
But it's very unique in the sense it takes Indian engineers and American engineers, throws them in an emergency room and lets them come up with 200 ideas. They have to go into our design school, whittle it down to 5 ideas, and then they get into our business school and come up with one business plan, and then go back to India and manufacture it at an Indian price. Is that
Yes, that's correct.
It's unique. We're expanding this now to Singapore. I did speak to the Minister of Health of Rwanda before he left to go to greater places, but I think that's what Stanford is great at, this multidisciplinary approach. It's not only engineers, but it's medical. Who else is in your group?
So we have a multidisciplinary team. We have 2 engineers, including myself. We have 1 doctor and 1 biologist.
And other teams can
And
have other...
right. And other teams, like the current Singapore team, is similar to ours. It has 2 doctors on board and 2 engineers. And both doctors have different backgrounds. So yes, they're all very multidisciplinary.
And the goal is to have the lead be the partners. It's not the U.S. widget that we've created. It's, we're not transferring somebody from one bed to another. It's really important in their trauma situations, but maybe not so here. So it's very need-based at the place.
Right. That's true.
I don't know, does that resonate with
That's very cool.
sure.
Very cool.
Another
our
part,
entrepreneur there? Does it resonate with you?
Yes, it does.
Sorry. Go ahead.
I'm from a large medical device company, Boston Scientific, and I sat in on this because first of all, I have a real passion to working with exactly the opposite of what I've done my whole career, which has been very high technology, but I'm kind of entering the second half of my life where I want to do something very different, and I really want to do technology that is very simple. I'm a mechanical engineer and Berkeley trained, and I've always done medical devices, but I'm very tired of high tech because I see such a huge population of the world that doesn't get any of the devices that I build. And I've done some reading, and I just want to know if there's a way. Our company right now, I'm trying to sort of negotiate my second half of my career, and part of that, I'd like to stay where I'm working, and we are starting to do, we have a big emerging markets initiative, which is to go into India and China. And so I want to partner with places like Stanford, and that's why I came here, to reach out and find out, well, how can where I'm working be the place where I do what I have a big passion to do, rather than just, completely starting from scratch. And maybe eventually I'd be able to completely work on only low-tech devices. But we have an initiative to move into these countries, not only for lower cost of labor and what everybody always hears about, but mostly to get into those markets to understand what is the patient need that's not myopically US-based and Western medicine-based, because just from a little bit of reading and from your presentations today, it's not all about, okay, cancer and pacemakers and defibrillators, but it's women's health. It's just saving like women and children, like very basic, and getting access to that. So, you know, if anybody is open, I really want to find out how we can partner, because I want to be able to do what I'm doing and eventually move into this space, which is very, it seems like I could have a bigger impact in my life on a lot of people.
Thank you for that. But I also think, I don't know which of the speakers talked about it, about the dual burden of disease as these countries start to transition. We just with biodesign, they are going to need your devices, but just in a different and
Maybe not the expensive ones.
different price. Yes, go ahead.
Let me provide an advice to corporate organizations. As a policymaker in a third world country, what I've seen is that when we sit at a table to do our plans and negotiations, we do not see the corporate organization at a table. We only see the donors, the defeat, those governmental groups coming to sit and engage governments. But we need to branch out to have corporate organizations sitting also at a table. If you have those technology, low-cost technologies, this is the time to discuss with governments that this is what we want to do. And you don't need to go through any donor organization to be there. You can directly engage governments, especially African country governments.
Oh, sure. Oh, sure. So my name is Christina. I'm actually with one of these corporations you speak of. I work at Novartis Vaccines. We manufacture, we don't manufacture malaria. We don't do anything. We're not working on malaria, but yeah, we don't. But we're working on a number of other vaccines that hopefully would be helpful for countries in Africa, like Rwanda and Ghana. I don't know if you guys have heard of GBS group, B streptococcus. We actually just entered phase 2 trials in Mali, and are very excited about potentially bringing a vaccine to the developing world before it gets to the US due to some of the hurdles within the FDA, given the regulations that we heard of this morning. My question to you guys, and similar to other people's questions on partnering, is just what we can do as a corporation from the commercial perspective to better understand the challenges and educate ourselves on the needs of how to provide solutions to countries such as the countries that you've worked in a way that's, if not profitable, at least cost neutral. Thank you.
Go spend time in the country. You can't learn about a country, the culture, the challenges, or the problems by visiting. You need a year, you need 2 years in country.
Engage.
Yep.
Yeah, you need to engage governments.
Yeah.
Yeah, this part of the program that Michele Barry described of actually having engineers work in emergency rooms to kind of see what the problems are. So one of the problems I tried to explain in my presentation is that often, you know, here in this country, we're rich enough that we can afford to generate solutions to problems that don't exist, and eventually, you know, there'll be a match. There'll be a solution that actually matches the existence of a problem. But in the developing world, you know, we shouldn't have that luxury. I think your question is a really good one, because trying to figure out exactly how to target the creative and innovative energies a little more effectively for the highest priority needs is perhaps the largest challenge in what we've talked about today. And I think getting out there is a cool idea. There are programs that have identified priority needs. And also in partial answer to the question you raised earlier that I think wasn't answered is, you know, while India and China are massive markets, and you heard lots of entrepreneurs talking about targeting those markets, a lot of African countries don't have exactly a critical mass of an economy, you know, so nobody's going to really target the health problems in, Rwanda or Burkina Faso. But you mentioned multiple countries, and I think there are opportunities to work with regional organizations and the Economic Commission for Africa and, the New Partnership for African Development and some of these other ECOWAS, some of these other regional organizations, and to really work with communities of countries and target those markets and target those health problems. So that's.
Yeah.
I would say as Deputy Director for Leadership.